እንደምን አደራችሁ?
እግዚአብሔር ይመስገን።
ዶክተር ወንደሰን ዛሬ የኮቪድ አፕዴት ነምበር 4 ያቀርብልናል። እስካሁን 3 አፕዴቶችን አቅርቧል። በጣም ነው ማመሰግነው ዶክተር ወንደሰን በአጭር ኖቲስ ዌቢናሮችን እያዘጋጀ ሼር ስለምታደርግ እና ፓርቲሲፓንትስም እናመሰግናለን። አንድ ሰው ቻት ቦክሱ ላይ ሪኮርድ ማድረግ ይቻላል ወይ ፕሬዘንቴሽኑን ብሏል። እኛ ሪኮርድ አድርገን ቴሌግራም ላይ አፕሎድ እናደርገዋለን። የባለፈው አፕዴት ስሪውንም አፕሎድ አድርገናል። ስለዚህ የጥቁር አንበሳ ሆስፒታል የሚለው ቴሌግራም ግሩፕ ውስጥ ጆይን ካረጋችሁ ሁሉም እስካሁን ድረስ የተደረጉ ኦልሞስት ሁሉም ዌቢናሮች እዛ ላይ አፕሎድ ተደርገዋልና ከሱ ላይ ዳውንሎድ ማድረግ ትችላላችሁ። ራሳችሁ ሪኮርድ ማድረግ አይጠበቅባችሁ። ግን ይሄንንም ሪኮርድ ማድረግ ከፈለጋችሁ ትችላላችሁ። ሪኮርድ ማድረግ ችግር አይደለም። ወንዴ መጀመር እንችላለን።
Thank you very much, Dr. Helen. So today we are going to discuss about the updates on the pulmonary manifestations of COVID-19. These are the learning objectives. I would like to discuss about, really identifying pathophysiological patterns for triage and respiratory support in COVID-19. The knowledge is very critical because it would help us how to manage patients when they present with acute respiratory failure. I'll try to define the role of non-invasive ventilation in COVID-19 pneumonia, discuss the amount of oxygen supplied by the various devices, explain the benefits of prone positioning, and discuss the risk of pulmonary embolism in patients with COVID-19. So these are the key points which I'm going to discuss during my presentation. So COVID-19 pneumonia does not typically cause the classic AR death, and as has been noticed at various areas in the world, the mortality rate far exceeds that of typical AR death. And I'm going to discuss about pulse oximetry because this is a very important tool for us to measure oxygen saturation, and it is a non-invasive test. And I'll try to discuss some very essential points about pulse oximetry and the study which we have planned to do. And there are 3 phenotypes of COVID-19 pneumonia. So these are the hyperacute course, the indolent course, and the biphasic course. I'm going to discuss that, and we have really understood that early intubation complicates the prognosis. So as much as possible, intubation should be deferred. But at this point in time, we have to know the kind of patient who would benefit from intubation according to their presenting symptoms and signs. Prone positioning helps to improve blood flow to the less affected ventral areas of the lung, and it also reduces lung compression and hence improves ventilation perfusion. So earlier on, the emphasis was on patients with mechanical ventilator, but now we emphasize that all patients, even if not on mechanical ventilator, prone positioning should be tried. And PTE is a very important risk factor as a cause for mortality in patients who are hospitalized for COVID. So I am going to present the most up-to-date data in relation to this key point. So before I do so, I would like to explain these very basic terms, hypoxemia and hypoxia. Hypoxemia means inadequate oxygenation. So it refers oxygenation takes place in the lung. So problems in the lung may be related to diffusion or ventilation perfusion mismatch or shunting. And hypoxia is inadequate delivery of oxygen to tissue. So there is a difference between these two terms, and we have to really understand the difference and then the similarity too. So the whole point is, the COVID pneumonia, does it cause the classic typical, the features are shared by typical classic ARDS. I would say it causes ARDS, but we need to remember that ARDS is such a heterogeneous phenomenon. However, compared to the classic ARDS that we do see, COVID pneumonia causes there are certain differences, one of which is very high or excess mortality rate, as has been noticed at various areas in the world. So in intubated patients, at least 40 to 50% of patients die, and it all depends in where they are being managed. In fact, in some areas as high as 80%. So the mortality rate is far exceeds that of the classic ARDS. What we know is COVID-19 pneumonia leads to hypoxemic respiratory failure, initially due to the coexistence of interstitial edema and altered pulmonary perfusion. So there is dysregulation of pulmonary perfusion in COVID-19. But the most important thing to understand is all these occur, the events which I described earlier, the dysregulation of pulmonary perfusion and impaired diffusion as a result of interstitial edema. All these occur in the absence of significant loss of lung volume and compliance. So what we expect with ARDS is a loss of compliance. However, in this, this is a very heterogeneous disease. So there are instances whereby the compliance would be lost, but in most of the phase, the compliance is preserved, and not only the compliance of the lungs, but the lung volume is also preserved. What we have noticed is when we calculate the PF ratio, it is below 200, which fits to moderate or severe ARDS. However, response to PEEP, which is a positive end expiratory pressure in CPAP, is not at the same as classic ARDS, because there is less alveolar recruitment, in relation to PEEP and CPAP use. So what we have come to realize is, there are 3 stages in ARDS. One is the exudative phase. This is due to the inflammation, and you'll see neutrophils and also the mononuclear cells, but neutrophils have the major role here. The exudative phase, there is a phase called proliferative phase, and the last phase is called a phase with fibrosis. So what happens with COVID is there is enhanced fibroproliferative phase, which is not common with other conditions which result in ARDS. So my point is, no doubt that COVID-19, when it gets complicated, that it causes ARDS, but the ARDS it causes is not the same as the ARDS that we do know. For one, there is an excess mortality, and 2, there is no loss of lung volume or compliance issue, as worse as seen with classic ARDS, and recruitability is also less compared to classic ARDS. So this is a standard definition for ARDS, and here we can use SPF ratio, which is the peripheral oxygen saturation to FiO2 ratio, and this is called the Kigali modification. And if it is less than 315, then by definition, this is ARDS. The problem with the Kigali definition is we cannot say mild, moderate, and severe. We cannot classify as the Berning's criteria does. So this is very important concept to understand in identifying patterns during the triage, so that how we plan to treat these patients. So there are, what we have come to understand is, there are multiple mechanisms of dysregulation in pulmonary perfusion. Okay, this is a very important concept. And what we have known is there is a diffusion impairment problem because of problems in the interstitium as well as in the alveoli. And there is also dysregulation of pulmonary perfusion. And this is described by one, what we expect when there is hypoxia is pulmonary vasoconstriction. And this response to hypoxia is abolished. And the end result is when there is no pulmonary vasoconstriction, what happens is there is an increase in venous admixture. The carbon dioxide content will increase. And in the segments which are not affected by the process, there is the segment affected by the process, there is an excessive vasoconstriction, whereas in lung segments not affected by the process, there is vasodilatation. So the response to hypoxia, the classic response, pulmonary vasoconstriction, is not seen in the segments which are affected by the process. And above all, there are micro and macrovascular thrombosis. So now patients could present with hypoxia, acute respiratory failure due to shunt or due to an increased dead space. So patients with an increased shunt would present with a variable work of breathing, meaning signs with respiratory distress. And these are patients who could benefit with non-invasive ventilation. Okay, so the patients, now if a patient presents, with hypoxemia, by definition that is below 94% O2 SAT, and bilateral pulmonary infiltrates are seen by chest X-ray or a CT imaging. And patients manifest with signs of respiratory distress, okay? And some, in fact, wouldn't manifest with symptoms or signs. They would have symptoms, but might not have signs of respiratory distress, which we called the indolent or the hypoxemic. So these are the kind of patients who could benefit from non-invasive ventilation. Whereas, with thrombosis, what happens is the area of the lung supplied by that vessel is devoid of blood supply. So the dead space increases. So when the problem is due to a dead space, there is an increased work of breathing, and patients will present with severe distress, like a state with a hyperacute, or which we call hyperacute. Soon after the start of the disease, patients would become severely hypoxemic, would manifest with an excessive, work of breathing. And these are the kind of patients who we directly should proceed to mechanically intubate. So my point is, depending on the phenotype, how patients present with, like, hypoxia with less marked work of breathing manifesting, like signs of respiratory distress, we can try with non-invasive ventilation. But patients who present with an excessive work of breathing in severe respiratory distress, their problem could be due to an increased dead space. These are the kind of patients who we need to directly proceed to invasive mechanical ventilation. These are the kind of patients who would benefit most from vasodilators and immunomodulators too. So my point is, depending on the patient's initial presentation, with adequate evaluation, we can gear, or we can decide on which path to follow, the non-invasive or invasive ventilation. That's my point. So hypoxia is seen in hypoxemia is a presenting sign in 15 to 20% of patients, as has been seen in different parts of the world where COVID had manifested in its full scale. And ARDS is seen in nearly 50% of patients with severe disease. So when patients die, they die from ARDS plus minus multi-organ failure, particularly the cardiac and the kidney. So this is a paper published from Mayo Clinic, and it associates presenting, with hypoxemia and an increased risk of days in the hospital. What has been shown is patients, what we need to understand here is when we say hypoxemia, the standard definition is below 94%. So there should be a chest X-ray or an imaging which shows a bilateral at least process which involves more than 50% of the lung parenchyma. And when patients present with hypoxemia, and that is an independent risk factor, the risk is 2.6, almost 3 times more compared to patients presenting without hypoxemia as a cause of death. So hypoxemia is a negative predictor or an adverse predictor of mortality in severe COVID patients. So there are ways by which we can measure oxygenation or detect the oxyhemoglobin concentration in arterial blood. A non-invasive means is a pulse oximeter. The arterial blood gas measurement is an invasive means. So we rely on pulse oximetry, okay? So because this is an indirect, painless, non-invasive measurement of the oxyhemoglobin concentration in the arterial blood. It's an indirect measurement, so when it is properly used, the information, it helps us manage these patients, okay? Patients whom we think are hypoxemic. So the device that we use is a pulse oximeter. So pulse oximeter measures oxygenation indirectly, and as I have said, it's painless, unlike arterial blood gas measurement, whereby you need to draw blood from radial artery or most commonly from radial artery. And the pulse oximeters use probes to shine, it shines light, red light, which is absorbed by oxyhemoglobin. And the deoxyhemoglobin is the oxygen, not bound to hemoglobin. So there is a difference in absorption, and this difference is sensed by photoplethysmography in arterial blood, detected by its pulsatile flow, and it subtracts the non-pulsatile component and the ratio, which is seen as which we read as oxygen saturation. So the target when we are managing patients should be above 90, and the normal oxygen saturation is 94. So now, if a patient is in a state of shock, shaking, shivering, with methemoglobinemia, carboxyhemoglobin, and so on, these are limitations for this test. However, if this test is properly used, it would give us a very important information to diagnose patient's condition as moderate, severe, or critical. So in our case, as you know, at this, you might have tried to measure your oxygen saturation by yourself, and you might have noticed that yours is 92, 91, 93. Most often it is below 94. And as you know, Addis is at an altitude of 2,000, nearly 2,400 meters above sea level. And myself, Dr. Idna Kacho, and Dr. Adana are trying to study the normal population distribution of oxygen saturation in Addis Ababa, because this is very important. By definition, if a patient has an O2 saturation less than 94, he is labeled as hypoxemic. But that has to be corrected to the local physiological parameters like altitude and so on. So it's best predicts, now we are trying to correlate oxygen saturation with arterial blood oxygen measurement. And this is a sigma curve. So the best correlation is when it is above 75, below which it lacks sensitivity. So a saturation less than 75 is not reliable. And above 90, it's almost, the curve is flat, so can't differentiate major change. So if you take, by definition, hypoxia is defined, when it's less than 60 millimeter of mercury, that correlates with 90. So you see the difference. When it drops to nearly 40, the saturation falls only by 10%. So the best measurement is arterial oxygen saturation, but that is an invasive means. So we are trying to rely on oxygen saturation, but we need to define the normal distribution of oxygen saturation in our population, and which we are going to study. Okay, so what we have come to realize is hypoxemia is related with not only with parenchymal process, but by and large is mainly due to thrombosis, micro and macrovascular thrombosis. So this would increase the dead space, and and that's why patients, particularly in severe ARDS and requiring mechanical ventilation, early institution or early initiation of anticoagulant therapy is really critical, because what has been shown in a published study, in post-mortem study, published in New England Journal of Medicine, is risk of thrombosis is 9 times more with COVID compared to H1N1. And as you would see, the feature is that of ARDS, meaning that is a diffuse alveolar damage. So in this case, they took lung samples from patients who died of COVID, and also a similar number, 7 patients who died of H1N1, and another patients who died of something else as age-matched control. And what they have noticed is risk of thrombosis in the capillary is 9 times more with COVID compared to influenza. So that's why we say the ARDS caused by COVID-19 is not the same as the ARDS that we commonly encounter or that we used to encounter before, because here there is an increased risk of thrombosis. Here you see 9 times more. And that's not only the case. There is, what we couldn't explain was the loss of pulmonary vasoconstriction in the presence of severe hypoxemia. And that's explained here by intussusceptive angiogenesis, meaning the vessel is blocked So there's a kind of collateral circulation developing surrounding. So the surrounding areas are hyperperfused. So maybe that is one of the reasons why in the segment that's affected there is an intense pulmonary vasoconstriction, excessive pulmonary vasoconstriction, but in the surrounding areas, in the lung segments not affected, there is pulmonary vasodilatation. So this is a very strong evidence which showed that we are not dealing with the classic ARDS. It is ARDS, but what makes it different from the classic ARDS is there is an increased both microvascular and macrovascular thrombosis, leading to an increased dead space. So you can see here, this is a lung. You could see thrombosis, and here you see again, this is lymphocytic infiltration, suggests the inflammation is due to a viral illness, and that is a SARS-CoV-2, and you see microthrombi in the small vessels, and also you would see infiltrates in the lungs. So the changes are similar to ARDS, but the risk of thrombosis is very, very high. Okay, so these are all supportive evidences, and now we have come to understand that this is a process which primarily affects endothelial cells, because endothelial cells have ACE2 receptor. So the endothelial injury exposes von Willebrand's factor and its release. This results in a hypercoagulable state, and and in addition to the cytokine storm, because with hyperinflammation there is a risk of thrombosis. So altogether, all these changes, if we compare COVID-19 with influenza, so COVID has more inflammation, so more cytokine storm, more endothelial injury, more thrombosis. This is how you should understand. So that's why it has high mortality rate, because it doesn't only impair the oxygenation, because the alveoli are filled with exudates. There is a diffusion problem, and also now there is a circulation problem because of macro and microvascular thrombosis. So what we have come to realize is patients, earlier on in Wuhan, and then similarly in US too, patients were directly, most of them were put on mechanical ventilator. So what we have come to understand is patients put on mechanical ventilator are more likely to die. So you see the mortality rate. So you see with invasive ventilation compared to non-invasive ventilation. So what we have come to understand is in invasively ventilated patients, the risk of death is excessively high. So what we have come to understood is early intubation complicates the prognosis. So it's better to manage them with non-invasive ventilation. But the point is, at triage, we should be able to differentiate patients who would directly should go to mechanical ventilation, like the hyperacute patients, because of an increased dead space, because of increased work of breathing, and a non-invasive ventilation should be the way forward for patients with less work of breathing, and maybe patients who can improve with prone positioning and CPAP and high flow nasal cannula. So this is a study in New York. So among mechanically intubated patients, 88% died. So you should take it, this is among so with all the drawbacks, because we resort to mechanical ventilation in patients who have, these are the kind of patients selected by physicians because they cannot be managed in any other way otherwise. So this is an established fact now. So, but we can't really rule out the risk of aerosolization and risk for healthcare workers when we implement non-invasive ventilation. So that could be the drawback because of aerosolization, and definitely there will be a risk to healthcare workers. However, the prognosis seems to be better if patients are managed with non-invasively compared to invasive ways. Okay? So now here we have come to realize that this is a condition which has to be treated with an antiviral and an a steroid like dexamethasone, and oxygen is required in patients who are hypoxemic. So this is a stage that corresponds with the stage 2 and the hyperinflammation stage. So now, if patients are not going to be managed with invasively, so the way forward is to institute a low oxygen with low flow nasal cannula. Steroids now have been established as a critical element in managing these patients because studies have proved that there is mortality benefit, and there are different masks which I'm going to discuss, and prone positioning is found to be really, really useful. Because these are the different tools that we have to administer oxygen. So the first is a nasal prong. The maximum oxygen fraction of inspired oxygen which we can deliver with nasal prongs is 40%. So FiO2, we can't deliver more than 40% FiO2, okay, with nasal prongs. So if you see this is oxy mask, we can give up to 60% FiO2, and the maximum is the range is 6 to 10 liters per minute. And here we have oxy mask with reservoir bag or non-breather. Here we can deliver up to 95% FiO2. So this is very important tool. Here there is a bag, so which the oxygen accumulates, and the patient will rebreathe from this. So this is called a non-rebreather mask. So this is something really was found really, really helpful in managing patients non-invasively. So this is a Venturi mask. Venturi masks can give up to 60%. This is the amount of oxygen that can be delivered per minute. But nowadays, people are using more and more oxygen mask with reservoir bags or non-rebreathers. I don't know why we don't have this in ECA Kotebe. I don't think it is really difficult. So we have to figure out, means whereby we can have this oxymask with reservoir bags. I don't think it's difficult. Also, there are these Venturi masks. High flow nasal cannula could be used, like this one. So this is in order to encourage us, those of us who are managing, to try to deal with non-invasively, because invasive management has high mortality compared to non-invasive. So these are different means. A helmet was used by Italians. So here we have high flow nasal cannula. So most areas in the US and in Europe use now high flow nasal cannula and non-rebreather masks. So this is used by Italians. So the prone positioning, it improves oxygenation to the ventral areas of the lung, okay? Because if perfusion is improved, so definitely the VQ would improve, and also the mechanical compression to the heart and to the lower parts of the lung is also relieved. So prone positioning, according to a study done in 2003, patients with severe ARDS was found really useful. So now we are trying this even in patients who are not intubated, and it's really, if used appropriately, so it might not be comfortable to patients, so they have to assume a prone position for most of the day. And the problem is when they assume supine position, significant number of them will lose the benefits that they got in terms of improved oxygenation or O2 saturation. So our colleagues at St. Peter and Eka Kotebe are using this prone position even in awake patients, okay? So it's really helpful. So you could see here how O2 saturation improves, but the problem is when patients are back to supine position, so they will lose the benefit. So significant portion of them would lose benefit. So patients who improve with prone can be managed with non-invasive ventilation, because maybe the dominant factor would be shunt in the causation of hypoxemia. So there are a number of studies which have emerged, published, and all showed that it is beneficial, but the limitations are, and we are not able to sustain the benefit that's obtained when patients are in a prone position. So last, I would like to discuss about pulmonary thromboembolism in COVID-19. So as you are all aware of, so our hypothesis is SARS-CoV-2 causes damage, downregulates the AC2 receptors. Okay, it binds to AC2 receptors in the lungs, type 2 alveolar cells, and the result is the angiotensin II level increases, whereas this protective angiotensin 1-7 level reduces, superoxide increases, it causes an endothelial dysfunction, and von Willebrand's factor is released, and the end result is thrombosis. Okay, so this is our hypothesis, and it's being and now and then being proved that it is the main mechanism how this disease operates. So this disease is a disease primarily affects the endothelium. So it's an endothelial disease. Okay, so what has been shown in these published papers, there is an increased risk of thrombosis up to 1/3 of patients in the ICU when imaging studies are done. So what we have failed to come up is, best predictive tools for the kind of patients who are more likely to have thrombosis than not, because risk factors like Wells score and so on, even adjusted for the D dimer values, have limitations. So what we have come to realize is up to 1/3 of patients, in the ICU would have PTE, and surprisingly enough, most of it is not recognized. So it's recognized, when patients die. So unrecognized, particularly patients who are on mechanical ventilators. So it's the challenge is, so the challenge we have is to really know what are the kind of to figure out risk stratification models that really predict reliably the kind of patients who are at risk of having pulmonary embolism. So the guidelines, now the practice guidelines recommend all patients on mechanical ventilation, unless contraindicated, to be fully anticoagulated. Okay? So this is an endothelial process. That's again from paper published in Lancet Hematology. And these are particularly the von Willebrand's factor. You see here, all these factors, D dimer and so on, are increased more these are all procoagulants. So procoagulant factors are released more in patients with COVID, severe COVID, compared to patients with non-severe COVID. Okay, so what we used to think was the platelets, microthrombi due to platelets, but now we have come to realize that there are also megakaryocytes. These are precursor cells. So these are released. So these precursor cells are seen in the lungs, in the kidney, in the heart, and so on. So we are dealing with a condition. There is, in fact, a hypercoagulable state, which is not only due to platelet-rich thrombi alone, but even their precursors, megakaryocytes, are also released. Here you see thrombosis in the lung. Here you see in the kidney, in the lungs, and the heart. This is PTE. So these are post-mortem studies. So what we have understood is, PTE should be considered seriously in hospitalized patients, and the standard of care dictates all should receive, prophylactic doses, but patients who are severely critically ill should be fully anticoagulated. And although there is a risk of hemorrhage, and the trend nowadays is to fully anticoagulate these patients. Okay, so these are the key points, and if you have questions, I'm glad to discuss. Thank you. Len? Dr. Ellen?
Yes, Wendy.
Questions, if there are questions?
Thank you, Wendy. If there are any questions, chat box live or raise your hands, and then you can unmute yourself and talk. Or I think I have seen Dr. Tedros, internal medicine. No, I'm just inviting him. Pulmonary manifestations ስለሆነ ቶፒኩ if he has any additional comments. አንድ ጥያቄ አለ chat box ላይ ይታያል እንዴ?
አይታየኝም፣ ንገረኝ።
chat box ላይ any comments on monoclonal antibodies and dexamethasone as treatment modalities ይመስለኛል። Okay.
The combination as, the monoclonal antibodies, particularly the anti-IL-6-1, interleukin-6 anti-monoclonal antibodies, in earlier studies showed benefit, but nowadays I don't think, the studies have shown real benefit. So particularly the earlier studies were done in China, in the Wuhan, and taclizumab showed some benefit. But these days, because they are specifically targeted toward this one or more cytokine, interleukin-1 or interleukin-6, their benefit is limited now. So the benefit is shown beyond doubt for dexamethasone. So people are more inclined to use dexamethasone. But mind you, the way forward should be remdesivir with dexamethasone. So the recovery trial, they did not use remdesivir. So if both are used, then we'll see what is going to be the change in mortality. So I hope the studies would come that would tell us, remdesivir with dexamethasone. But no monoclonal antibodies. So far, there is no study which showed a mortality benefit on its own. Okay, when evaluated with when analyzed with multivariate analysis. Teddy Ross, you have comments? You can. Teddy, you have.
አይ ተሳስቼ ነው ወንዴ የእሱን አካውንት አይቼ በሱ አካውንት አይ ቲንክ ሌላ ሰው ነው የገባው ዶክተር አሚር the role of imaging in predicting patient prognosis ሚለው
Yeah. So we have to be really very careful. The imaging, you know, even asymptomatic patients would have CT or chest X-ray findings that suggest a bilateral process, ground glass opacities, but it's very difficult to correlate the amount of lesions seen in the lungs with the clinical severity, okay? Because patients with little or no symptoms can have a florid manifestation. So I haven't come across any study which tries to correlate the amount of change seen with the patient's clinical presentation, meaning severe, critical, moderate, and so on. But what we have come to realize is the most important factor is hypoxemia. Okay, hypoxemia. Hypoxemia, you know, if detected at admission, it means unless dealt, you know, systematically, and it carries, you know, it's a very an independent, poor prognostic indicator. So what I am trying to present today is, you know, depending on the patient's presentation. If patients have an excessive work of breathing at the time of presentation, really hypoxemic, really in distress with bilateral, you know, if there are chest X-ray findings or imaging studies, then these are the kind of patients who should directly proceed to invasive ventilation. But patients, you know, majority are not presenting in as hyperacute, meaning they are indolent, meaning they are hypoxemic but without symptoms, definitely hypoxemic without symptoms. So these are the kind of patients whom we should avoid invasive mechanical ventilation. We should try them with non-invasive, like face masks and nasal prongs and non-rebreathers and high-flow nasal cannulas and the like. Okay, so we should avoid using mechanical ventilation as much as possible. So, but we shouldn't delay for those patients who really require. Okay, particularly those who are presenting with hyperacute or you know, in short period of time, you know, with severe distress and increased work of breathing. This is what I am trying to imply. So we can manage most of the patients without mechanical ventilation. That's what I am trying to imply. So there are certain patients who require, so we need to identify these patients, and there are certain phenotypic or clinical variables that would help us to identify these patients at triage. So patients, you know, who can be managed non-invasively should be managed non-invasively because the prognosis is much better. Okay, that's the whole point of my presentation today. And we shouldn't forget to anticoagulate them unless there is a contraindication, particularly those who are severely or critically ill should be fully anticoagulated. That seems a way forward.
Thank you, Wendy. The next question is about the target INR or PTT during anticoagulation.
That is the same as standard treatment for PTE. We shouldn't aim outside that because there is an increased risk of bleeding. There is an increased risk of bleeding. In fact, some patients died from bleeding-related complications. So if we are using low molecular weight heparin, that's which I really recommend, then that would be safer. That's what I suggest. So we manage them the same way as we manage PTE patients. So there is no difference. The point is the risk of PTE is by far higher compared to other conditions that result in AR deaths. So now things are, every day things are coming very clear for us, the way we should manage these patients, okay? So the way forward seems to be an antiviral, an immunomodulatory agent or steroid, and anticoagulant. That seems to be the case for the critically ill patients, severe and critically ill patients.
Thank you, Wendy. That was an excellent presentation as always. Thank you so much.
Thank you very much.
Participants. Have a good day.
Okay, same to you. Thank you very much.